This is video 14 in the Tulip Airway series. This video is all about difficult and dangerous airways and is designed for experts. The last video was basically designed for paramedics and nurses and those who find difficulty in establishing an airway, those who aren't anaesthetics or anaesthetic consultants. And this one is for the experts. It is for consultants. I think you'd agree that coming up with something new and useful for an expert like an anaesthetic consultant is going to take some doing, but happily we do have exactly what you need in times of trouble. Now what I'm talking about is difficult and dangerous airways. So we're talking about airway burns, ENT, post-tonsillectomy, blood clots in a patient's mouth, anatomically difficult airways consisting of things like cancers and tumours, and post-trauma, a patient hitting their face on something unpleasant. I mean, we are talking about anaesthetics' worst nightmare. So I want to be very specific. This is for experts. Clearly, a tulip that's easy to use for a child is going to be easy to use for an expert, but we're going to show you how to manage a seriously dangerous airway, and I'm going to use airway burns as an example. Now, let's talk about airway burns. Okay, so last time I intubated airway burns, it was just a mess. Of course, you're limited time. You don't know, where the mucosa leads. You don't know if this is the trachea or is that. And basically, the use of a laryngoscope just seemed to make things worse. There was more bleeding, more edema. Just couldn't see anything. So the recommendation in this case is don't use a laryngoscope. Go straight for a tulip. Allow the tulip to fit. Now the good news is that a tulip actually works better in a difficult airway that's tight or edematous or has a tumour, because what happens is the inflatable cuff slowly inflates around the central breathing tube, and then it basically accommodates any irregularities in the walls. So if post airway burns, the airway is edematous, if it's sort of friable, bleeding, any of this, the tulip will basically not only gently compress the mucosa out of the way, it'll facilitate an airway even more quickly, because a tighter airway means the cuff, as it inflates, impacts the mucosal walls and the inside of the oropharynx much sooner. So if in a normal oropharynx it would expand to about that, but in a tight oropharynx it would expand to that, but it would get there faster. Again, monitor the pressures. The whole point is the soft airfill cuff accommodates the abnormalities that you find. So what happens is you establish IPPV control quite quickly with a tulip. It's directly connected. It's hands-free. It's delivering 250% more oxygen than a Guedel does. If we agree that a Guedel supplies with a mask supplies 60% O2. Now this is the new part for the experts. This is the bit that will save a patient's life. You leave the tulip in place. You're ventilating. You've got control. There's no concerns. It's not a sweaty situation. What you then do is you take a flexible bronchoscope, put it through an ET tube. You can use up to a size 7. I recommend 6s and 6.5 cuffed, because that's just easier to get in and out. And then you intubate through the tulip. Okay. Now with a bronchoscope in the ET tube through the tulip, you're likely not going to fail. Even if you do, in this situation of airway burns, you may not see what you want to see. You can just simply remove, and you've already got a ventilating airway in place. You've already got a tulip ventilating, directly connected, hands-free. All you've got to do is squeeze the bag. So you increase the sats, try again. But basically what happens is most occasions you'll see what you want to see, and you will intubate using the bronchoscope. But here's the important thing. The tulip stays in place whilst the procedure is being undertaken. All right, so you're going to need the tulip for extubation. So for God's sakes, don't take it out. Because remember, with a dangerous airway burn, something like this, dangerous, difficult airway, if you remove the tulip, you could lose the airway. So don't remove the tulip. Leave the tulip with the ET tube through it and conduct the procedure. Okay, so here is an example of intubation through a tulip, so you know that we're not just making this stuff up. Here we go. The tulip is designed not only for ventilation but also for inline
endotracheal intubation. If you introduce the tulip in the normal manner, if you inflate it in its normal manner, you will have a controlled ventilating airway. So if you imagine that the paramedic does this first, and then the consultant anaesthetist arrives with a size 6 or 7 endotracheal cuff tube that is itself lubricated, you can intubate through the tulip in such a manner. If I now inflate the endotracheal cuff, you will see that even blind intubation is possible. In a situation whereby a patient has a difficult airway, or in some form dangerous outcome potentially, we recommend that you intubate through the tulip using a bronchoscope through the endotracheal tube, because that way you will not fail. You do not need a laryngoscope. On extubation, you're also then free to remove the endotracheal tube at the end of the operation and then facilitate a self-extubation with the tulip when the patient themselves is awake. When the patient extubates, the patient is fully conscious. Laryngeal reflexes will have returned.
Now, I made a mistake there. You don't need to deflate the cuff on extubation. The patient will self-extubate with a fully inflated cuff. What that then also does is it keeps the breathing tube central as the tube comes out the mouth. So unlike an LMA or an iGel, tulip does not obstruct on extubation. And that's why you leave the cuff inflated, because it will also wipe the mouth free of secretions and blood, well, to as much as it can. I would still recommend suctioning, but what happens is the prime goal is with the flexible tube that you find on tulips is the tube will flex straight, but the cuff will still be around the edge, so as it comes out it keeps the breathing tube central in the mouth, therefore you can breathe at any stage of removal, unlike an LMA or an iGel, which, as you know, obstructs when it's not properly in place. So I've showed you how to intubate through a tulip, and you can see that it's possible, but perhaps I'll show you a bronchoscopy to show you just why it's so easy. Now, of course, blind intubation isn't going to work every time, I can't promise you that, but basically this is what you are dealing with.
That's as good as it will get, isn't it? Beautiful.
Now that is a bronchoscopy through a tulip, and you can see why intubation's relatively easy. So you can see that basically you put the tulip in, you intubate through the tulip with a bronchoscope in airway burns case for maximum safety. The patient is then intubated, you undertake the surgical procedure, e.g. number 7 on this list. But then what you do is what happened in the video. You remove the ET tube, leave the tulip in place, and then the patient will self-extubate. Now, when the patient self-extubates, they will be awake with the intact airway reflexes, as this next video of an old lady recovering will show you. So this is the old lady, and we're very grateful to her. This video was taken with her consent, and to me it's invaluable. At the very beginning, between seconds 1 and 2, she swallows, and then she coughs at about 8 seconds, and then again at about 10 or 12 seconds, like that. So you will see that her airway reflexes are intact. So imagine this in airway burns post-ENT, because, you know, what risk once they've got their airway reflexes? This particular lady clears her lower airway with a swallow. She clears her upper airway with a cough and then a gentle
ice, please.
So
Yeah.
You pull that out if you want to, Anne.
Of airway complications.
That's good.
That's the
Good.
point.
Excellent.
How do you feel? You wide awake?
Yes.
How's your throat feel?
Okay.
Thank you very much.
Now, this video is in a number of the other tulip videos, and I make no apology. Evidence like this is not easy to get. And as you saw, she swallowed and then she cleared her own airway. So, you know, in difficult and dangerous airway scenarios, this has got to be the ultimate recovery. And I am speaking to the experts and the consultant anaesthetists, and basically if any of you disagree, please let me know why. I'm quite happy to discuss it, you know what I mean? Now, when I say basically I think this is significantly safer, take the example of not only airway burns, but what about ENT after a tonsillectomy? We've all heard of the coroner's clot. Okay, can you still die of one if you have your airway reflexes back? Now, basically, as I said, the patient self-extubate fully awake. I'm considering GCS-14 with slurred speech to be fully awake. Now, the video proved that there was a return of both upper and lower airway reflexes. I think you saw that. Now, if that is the case, then self-extubation with a tulip surely increases safety for every single recovery in which a tulip is used. And if you use it for difficult airways, if you use it for airway burns, for ENT, for trauma, I think that's a significant step forward. Now, this is basically what a tulip looks like. Here's the 3D rotational CAD system drawings, but you can see right angle bend with a headband. It's self-retentive as well. The shape keeps it in place. Now, basically, here's the demonstration video, instruction video, how to use a tulip. Number 1.
This is the tulip airway. To insert, push down on the chin, place into the mouth, push down with your thumb and forefinger until it's level with the teeth. Take the syringe, 50 mils, insert into the valve, push firmly, inflate the device, keep your thumb on the syringe and disconnect. Take the bag, place directly onto the tulip and ventilate. Squeeze firmly and at approximately this rate.
Now, I'm not sure if you can see the pressure gauge that's just attached to the end of the bag there, but it's generating 30-40 centimeters of water without a leak.
A size 2 green tulip is equivalent to a green Goodell. For a mannequin, lube the device well. Put the cuff in the mouth first. With the thumb, push down and straighten the tube. Push straight in. Inflate to 50 mils before ventilating. Hold your thumb on the syringe before letting go.
So you can see the tulip's quite easy to use. It's very fast to establish. It gives you better IPPV performance than any other airway at the moment. It does so without a leak. It does so with the softest cuff of any known airway device. You should be keeping the pressures in the cuff at around 40 millimeters of mercury, right? So 50 centimeters of water. That's the same as mucosal perfusion pressure, which has got to be the softest thing you can find. But basically, you can see that the benefits of rapid airway control spread right across airway management, right across starved elective anaesthesia in all dangerous airway scenarios. It'll improve oxygenation, ventilation, and it's ultimately neurological protection. But look, basically me, banging on about my opinion isn't really what these videos are about, because what I would like you to do is read the experiences of other tulip users, other consultant experts, consultants like yourself, because improved outcomes have already been demonstrated, life-saving experiences. It's video 2 that I refer you to. I did think about adding it to this, but I don't want these videos to be too repetitive, and you'll see the bits and pieces. There's video 2 is about how tulips, stop cricoid thyroidotomy on a number of occasions. Now, those 3 documented life-saving cases, as I said, are on video 2. But bear in mind that all of them have been presented at international meetings. They've all been published. So this is the real deal. Now, this is a Tulip Airway website. Now, for a consultant, you're going to want to look at instructions for use, instruction manual. You're going to want to watch the intubation video again. There are other videos that are of help to you. In addition to all that, of course, you want to see the clinical data. The clinical data exceeds my wildest expectations. I recommend you read it. But the real proof of the pudding is in the using of a tulip. Once you use it, you will pretty much understand that, yeah, everything I've just told you is true.